Hello, I'm Dr. George Wortham. I'm the Chief Medical Officer of MetroCare Physicians. I've been in practice in Memphis, Tennessee now for 27 years as a OBGYN physician. I've practiced in multiple hospitals within the city. I've also been a member of MetroCare Physicians for approximately 22 of those years, and on the MetroCare board for about the last 15 years. I've also been a board member of Health Choice for the last 8 or 9 years. But thank you today for attending this webinar so that we may give you some information as to the future of MetroCare. We feel excited about its new direction, and we look forward to any input and conversation that we can have in the future regarding our changes. MetroCare is one of the region's largest independent physician association. It has about 1,800 members, 480 different practices. MetroCare was formed in 1983 and has involved physicians affiliated with Methodist Le Bonheur Healthcare since that time. There's been a lot of confusion regarding the difference between MetroCare and Health Choice. And I would like to try and clear that up right this minute. MetroCare, again, is the independent practice association that you have belonged to and paid dues to for all these years. Health Choice is the contracting entity that has been in place for also that same 30-year reign, where 50% is owned by MetroCare Physicians and 50% owned by Methodist Le Bonheur Healthcare. Health Choice has been our contracting entity. It has negotiated contracts specifically with the payers such as Cigna and United. These contracts have not included fee negotiations, but the payers have, using the messenger model, have then forwarded fee schedules through Health Choice to the MetroCare physicians and allowed physicians to opt in or opt out of plans in the messenger model that we have been currently using. In the future, we are moving from this model of messenger contracting into something called clinical integration. Clinical integration is an exciting new opportunity for MetroCare physicians to come together under one umbrella and function as a single multi-specialty group without walls. Clinical integration has a bunch of different definitions, but essentially it involves the same principles, such as we're improving patient care, trying to decrease cost, and hence demonstrate a value to the payers and the employers that are purchasing health care for their employees. In this model, performance must be measured, it can be rewarded, and then it must be reevaluated and corrected to improve quality and demonstrate value to the purchasers. Clinical integration was actually designated by the FTC, Federal Trade Commission. And in this definition, it says that physicians are allowed to come together, but they have to come together for the purpose of developing clinical protocols using evidence-based guidelines to set the way that they want to take care of their patients, using physicians to determine the metrics, determine the performance levels, determine the incentive plans, and adherence to the protocols is a key part of this definition. A critical piece of this definition also is that there is a common data repository and reporting structure. Because of these activities that the FTC requires, it also allows some benefits to the integrated network. And that is that for the first time, physicians, along with their partner hospital, can contract as a single entity and can contract not only for payer language and contract language, but also for specifically fees. Those kinds of fees can come in lots of different forms now as we move from fee-for-service to value-based reimbursement for physicians. Those contracts and incentive rewards can be negotiated on the front end in terms of designing bonus pools that can be used for pay for performance, and further on into other types of payment contracts. The demonstration of value for the patient, the providers, and the payers is a critical piece to this definition. The question is, why are we bringing clinical integration to the group now? Well, the answer is that this is really a market-driven initiative. It's the payers, the employers, the patients, and including the government that actually demand that the providers of health care demonstrate value because they're frankly sick and tired of their premiums going up yearly, sometimes 15%, sometimes 24%. Nothing's predictable. And it makes it difficult to run their businesses when those kinds of numbers jump up in front of them. So it's the market that's really forcing these changes, not on just our community, but on all communities across the country. Well, also the payers, Cigna, Blue Cross, United, all of the insurance companies have heard the same message from the employers that purchase their health care through their systems, that they want a predictable, slow increase in these premium rates. They want something controlled. Well, all of these payers are also coming up with their very exact plans to do that very thing. Well, of course, Cigna's got one plan, Blue Cross has a different. They're all using different metrics, different things to measure, different protocols. Granted, they're similar, but for a physician office to try to figure out which patient they're seeing, what insurance company they have, and which metrics that physician is being measured upon is essentially impossible if you have to do it 5 or 6 or 8 different ways. So we are proposing at MetroCare that we do this thing one way, our way, the way that MetroCare physicians will decide what guidelines, what protocols we will use. We will decide what metrics we're going to measure our performance by. We will decide what performance goals we have, and then we will educate ourselves as to how to do these processes, how to change our practices, and then again, we as MetroCare physicians will do the peer review and decide who's doing well and who's not doing so well. For those who are lower performing, MetroCare will have a huge presence in the area of providing education. For those who are performing well, it will be again MetroCare physicians that decide who receives incentive or bonus pay. We like this model because it's been performed in other cities, and in fact we're using the Medical Group of Ohio out of Columbus, Ohio as our primary model for what we are trying to institute here in Memphis. We like their model because their IPA started in a similar fashion to ours with predominantly independent practitioners, though there were some also employed physicians, as well as even a small contingent of some university-based physicians. And in that model, they had about 2,000 physicians in their IPA, and they started with about 800 or 900 who joined the clinically integrated network and have now grown that number to almost the full 2,000 physicians participating in their clinical integration program. The independence of our practices allows us to stay competitive with each other, and that independence, we know, creates that competition, and the competition is what drives innovation, and we all know that that's what the future is really demanding, that we innovate the way we practice and the way we provide services to our patients, and again, finding higher quality, lower cost, and stabilizing these radically varying premiums that are being charged. Well, that's the beauty of clinical integration. Because the FTC says that if you do all these things, you can then get a bunch of rewards that actually help physicians in a way that we've never been able to be helped before. Physicians in the past have never been able to negotiate fees as a unit. Under the clinical integration program, the FTC does allow physicians to negotiate as a unit. We will be partnered with Methodist Le Bonheur Healthcare. Health Choice will be our contracting entity, and together Health Choice can, as a single signature contract, negotiate fees for not only the physicians and the hospital together. That's an important distinguishing fact from what the way that we've been able to practice in the past. And when we do these fee negotiations, we won't be negotiating individual CPT codes for each practitioner. What we intend is that we will negotiate an escalator that will go across the board. For example, the hospitals in the past have been receiving escalators on an annual basis, somewhere in the neighborhood of 5 or 6%. We intend that when we do a contract with a payer in the future, that we take that same escalator that they've been used to paying and spread it across the board. Hence, physicians getting a portion, hospital getting a portion. So in other words, the entire boat will be floated at the same rate, hospital and physicians getting annual fee increases, small but real, something that we don't have now. The clinical integration program also allows us to negotiate bonus pools directly with the payers. It's then up to the physicians at MetroCare to decide how those bonus pools will be distributed. It allows us also to deal with the concept of gain sharing, where if, say, an insurance plan had a spend of $100 million last year, and under our clinically integrated program, they only spend $90 million this year, well, there's a $10 million savings to the plan. Well, in that scenario, say 50% of it would be shared with the employer or the payer, and the other 50% would come back to our clinically integrated network, and hence shared between the hospital and the physicians. Again, the physicians will decide how their portion of the fees will be distributed amongst the physicians. This infrastructure also allows us to do other value-based payment plans, such as bundled payments, where a single fee is paid for a single episode of care, say as for a cabbage, a single fee being paid to both the hospital and the physicians in a single lump sum. Currently, we have no infrastructure whatsoever as to how to decide those monies would be split. Our clinically integrated network will give us that format where that negotiation can occur between the physicians and the hospitals prior to offering that bundled payment service to a payer. One of the important things about the FTC designation regarding this potentially large 2-ton gorilla in the marketplace, it specifically says that you can't act as the large 2-ton gorilla in the marketplace, and that any kind of anti-competitive behavior would be clearly scrutinized by the FTC, and we have every intention of avoiding any problems in that area. One of the important pieces of that puzzle also is that physicians must be non-exclusive, meaning that they can participate in other clinically integrated networks, they can participate in other plans, and not be essentially held hostage by the clinically integrated network. In other words, there should be no way for a physician to be only accessed by a payer or an employer utilizing the clinically integrated network. The key difference to this time around with managed care is going to be that we have our own data. Currently, all the data is only held by one place, the insurance companies. The insurance companies have data on the outpatient side as well as the inpatient side. However, they haven't been very forthcoming with sharing that information in a way that we can actually do something with it. In our new entity, we will be, and we have contracted with a company called Valence, which is a company out of Chicago that has been doing data aggregation and analytics for about 15 years. They've been intimately involved with the development of clinical integrated networks across the country in places like the Medical Group of Ohio, which is our model, as well as Cleveland Clinic. They've also been participating in about half of the efforts by the freestanding pediatric hospitals in the country, and they have numerous other clients across the nation. The data is the key to this whole endeavor. We're going to have our own data. It will be claims data that is collected from our physician offices as well as from the hospital. We will have data from pharmacy benefits when we can. We will also have data from the payers. The key to having our own data is that we can then be sure that it is accurate and reliable. That's always been the problem in the past with the data-based scorecards that physicians have received. First, that data has come on a small group of patients. The acuity or illness severity of the patient has always come under question. Physicians have always questioned the validity of the data, and not to mention the fact that it was a small number of patients. It occurred 3 years ago. None of this kind of data is actionable. None of it can be actually used to transform a practice. Our data will be collected in a way that it is very timely, where data may be collected as frequently as a daily basis, but certainly no less frequently than monthly. It's having this reliable data that will then allow physicians to actually know where they are on their performance goals on an almost real-time basis, as well as this data will be sufficient to follow gaps in care or actually identify patients who need interventions prior to the time that the intervention is supposed to occur. Huge difference in what has happened in the past. This data will come in, as I said, from various sources, from the payers when they participate, not to mention from the hospital, our physician practices, laboratories, the skilled nursing facilities, Health South. This information will then come into Health Choice, where the Valence platform will be housed, and the data will then, and the analysis of that data will then be taken to the MetroCare physicians, and under a committee we're calling the Quality Enhancement Committee, that data will then be reanalyzed and new performance goals, new metrics may be developed to make the whole clinically integrated program more functional, more progressive. The type of data that we will collect with the Valence software will include patient demographics such as their age, their race, where they live, gender, those typical kinds of things. It will also, we will ask for information across all payer lines and also for a 2-year history on all patients. Both of those things, across payer lines and 2-year history, is important because many patients have changed insurance carriers even as frequently as a yearly basis. And to get a full history and full understanding of the patient's acuity of their illnesses, it's necessary to collect data over that period of time. The data will come in on an individual patient, which if you're in an OBGYN practice like me, you will commonly code out a preventative care visit, say a pap smear and then a mammogram. Granted, pap smear and mammogram may be important to capture for preventative care metrics. However, that same patient may also have hypertension, diabetes, or gout. Well, since as an OBGYN, I don't see that patient for those reasons, I would not code them out on my claims form. However, they see several other physicians who do care for them for those disease processes, and they would code out those disease processes, and hence, by collecting and aggregating that data in one place, that patient can be assigned the appropriate acuity of their illnesses, hence allowing us to really hone down to the issue of who's taking care of the sickest patients. And that is a common story that we've heard in previous attempts to measure physicians' performance, is that I take care of a lot sicker patients. Well, this data and this data aggregation technique will allow us to know that very thing in a very accurate and a very fair way for the physicians. The Valence software is really more like an app that would sit on top of a practice management system. It will not dive into the system, it's not connected to the NSA, and will not dig information out of your practice management system or your electronic medical record system. However, the way it will actually work is that when you make a claim and file it electronically to the payer, as you currently are doing, a copy will be made of that claim, which will then be sent to Health Choice, and the Valence data aggregator and analytics will then capture that data. So the information will be only in the push form. There won't be any digging into your system to find information that you don't want to share. A lot of questions have been asked regarding the HIPAA compliance and the security of the system, and Valence, again, has been in this business for a long time and is compliant with all of the necessary safeguards for this information. You can imagine from hearing how much work is going to occur to develop this clinically integrated network in our clinically integrated program that the MetroCare physicians are going to have a lot of involvement in this effort. And to do so, we are going to have to substantially expand our committee structure to accommodate all the facets of working in this clinical integration program. Currently, we've been doing credentialing for years as a delegated credentialer for the payers. We will continue doing that. However, in our new world, we were going to have to develop many other new committees. The QEC, or Quality Enhancement Committee, is the place where a lot of the heavy lifting will be done in terms of the committee work. This is the place where the protocols will be decided, the metrics and the performance goals will also be recommended. We will have a peer review committee that then takes the performance analytics, again from Valence, and reviews those, hence determining which physicians are high performing and those that are low performing. There will be a large portion of the job for MetroCare will be in the area of communications. It will be our responsibility to help the underperforming physicians learn how to transform their practices, make the changes necessary to then become a higher performing practice and hence receive their incentive bonuses and provide improved care to our patients. We will have a contract review committee where anything that is done within the clinical integration program, all aspects of it will be reviewed at the MetroCare level, and then in cooperation with our partner, Methodist Le Bonheur Healthcare, again, there will be negotiation and discussion at the level of Health Choice before a final plan is decided and then presented to payers. As I said, MetroCare physicians will have their input. The Methodist Le Bonheur Healthcare will have their input, all under the Health Choice banner, and then Health Choice will take that clinically integrated program that we have agreed upon to the payers and negotiate the fees, the bonus pools, and other payment arrangements that we will be looking to utilize. Currently out there is another attempt at a clinical integration program. Baptist has started the Select Health Alliance. It's a somewhat similar concept. However, their plan has been essentially a hospital-led program where the hospital has partnered with one of their longtime insurance companies, Aetna, and they're using a Crimson solution for their data repository and analytics. Aetna and Baptist have then selected physicians to participate in this program in terms of their advisory board or board of directors. That board has been, unfortunately, somewhat lacking in the number of primary care physicians involved. Currently, the MetroCare board is a 50% primary care board with 50% specialist physicians as well. And their initial attempt at Select Health will be on mostly inpatient metrics, looking at high-dollar imaging, generic drug use, and some various other things that are clearly important to the hospital side of the equation. What we're asking physicians to do now that are interested in participating in our clinical integration is to go to our new website, metrocarephysicians.com, and we hope that you will use this website in the future as a source of new and updated information that will be brought out to the physicians participating in our new program. We are trying to get away from meetings, as we know that physicians are unlikely and usually not very willing to attend more and more meetings, though any kind of meeting or committee work that is done within our program will be compensated, and physicians will be compensated for the time that they spend. We're trying to move into the new century and provide our communications in different manners through more readily accessible techniques. We, for that reason, also ask for an accurate email that you're willing to actually have some information sent to and review when it's necessary. I promise you that we will not be spamming your email address. We will only send you information that is important and critical to your participation. We're also asking that you to begin the dialogue with your colleagues and your partners and have them learn more about our efforts in this clinical integration program. Because of the FTC rulings and rules regarding these clinical integration programs, it's necessary to have a specific agreement that describes what we are doing. I believe that this agreement is in a fairly readable form for physicians, which is actually kind of unusual when lawyers may be involved in drafting these kinds of things. But these will be coming out soon, and we hope that people read these agreements and decide to participate. There is no increase in dues or fees to participate in our clinical integration program. We thank you for your participation in this webinar. We hope that you will find some interest, come to the website, and begin this journey with us into the future with our new clinical integration program. Thank you.